Good evening, everyone. Thank you so much for joining in for these, series of webinars that MUS has been conducting. So, what we plan to do during these webinars is we try and have a mix of, cases, some of them, some new concepts, some new topics, along with a mixture of some, common pathologies that we see in day-to-day practice. Okay, and maybe the difficulties that we face while scanning, in our clinics, and if we don't know, whom to ask or how to go about, any difficulties, we can, solve them over this forum. So, tonight we have Dr. Satish Pawar, who will be talking on an absolutely new topic, something which a lot of us don't really evaluate on ultrasound. So he's going to be talking on the popliteus tendon, how to scan the anatomy and the common pathologies encountered. This is something really new. So I think there's something in it for all of us. And of course, with that, we have Dr. Raleigh, who will be coming in next. She'll be talking on ultrasound evaluation of common lumps and bumps. And of course, this is something that we have heard quite often. But then every time I listen to a lecture on ultrasound evaluation of lumps and bumps, I always have something new to learn and take back home along with me. So before Dr. Satish starts, a quick just a request to everybody, whoever's joined in, please make sure that your microphones or your speakers are off, because it's really disturbing to the presenter, because if by mistake if you switched on and on, it creates a lot of disturbance. So with that, I think Dr. Satish, I think the stage is all yours.
Yeah, thank you very much, Ankit, for such kind words. First of all, I would like to thank Bipin sir, Nidhi ma'am, Ankit and Rajas for
Dr. Satish, yes.
Yeah, for initiating such a wonderful webinar series, which will be very helpful for all our colleagues. And we can learn many things from each other, and it will help a lot in your day-to-day practice. So today I will try to describe the anatomy, ultrasound evaluation, and a few pathologies of popliteus, which I have come across in last few years. So why popliteus tendon? See, it is one of the most least evaluated in day-to-day practice. And when I selected topic, I just went to the textbook of musculoskeletal ultrasound. But in all the chapters, I couldn't find much about that. So I will try to evaluate as far as possible. The popliteus is relatively a small but unique muscle of the knee. It is an essential structure to maintain the knee stability with its sophisticated anatomical and biomechanical features. It also acts as a major stabilizer of the posterolateral knee. Despite its importance functionally, the popliteus is underappreciated and incompletely evaluated by many clinicians and radiologists, and it is under-evaluated on the knee MRI too, with respect to the common problems of the ligaments and the menisci. So I have divided my talk into these parts as introduction, anatomy, neurovascular supply, functions, scanning technique and protocol, and common pathologies, and conclusion. So injuries of the popliteus are common and often occur with other posterolateral corner injuries. Its disorders are often overlooked in complex knee injuries. Isolated injuries of the popliteus are less frequent, occur mainly in athletes, and are characterized by pain around the insertion to the femur, along the tendon, and its attachment to the local structures. In some cases, the symptoms can mimic the lateral meniscal tear. The imbalance between the quadriceps muscle and posterolateral structures can lead to the increase of the load on the popliteus tendon, which can be observed commonly in the basketball, tennis players, and also who are doing downhill running. In the present scenario, post-TKR pain is one of the common clinical indication for ultrasound examination. And undiagnosed popliteus injuries can lead to poor functional results after reconstructive surgery. That's why a prior examination of the popliteus tendon as well as the muscle before doing any TKR will be very useful for the patient as well as the surgeon. High resolution ultrasound examination is easily available and can demonstrate the normal anatomy and wide varieties of pathologies. So what is the role of ultrasound? The ultrasound is a valuable diagnostic tool in assessing the following indications. We can see the muscle, tendons, and ligamentous damage, which can be chronic or acute. We can evaluate injuries. We can see the bursitis, all post-surgical complications of TKR, and it is very useful for localized injection, aspiration, or biopsy. And we can evaluate some bony pathologies too. So what are the structures to be assessed? So we will be assessing the popliteus tendon, popliteofibular ligament, popliteus muscle belly, the fibular head, and the subpopliteus recess. So where is the popliteus? The popliteus is a thin triangular muscle with a narrow tendinous origin from the lateral aspect of the lateral femoral condyle. This is the popliteal fossa and this is the origin of the popliteus tendon. It connects with the fibular head as a popliteofibular ligament as shown here, and the posterior horn of the lateral meniscus as a tendinous attachment. The popliteus tendon forms a strong cord and it is intracapsular structure but extraarticular and extrasynovial that runs deep to the lateral collateral ligament. So this is the reflected and the tendon which is shown here and passes popliteal hiatus. The average total length of the popliteus tendon to its musculotendinous junction from the origin to the myotendinous junction is around 54 millimeters. So popliteus tendon enters the knee joint through a hiatus in the lateral meniscus. Arthroscopy of the lateral compartment of the knee shows the popliteus tendon. We can see a bright tendinous structure going through the hiatus of the lateral meniscus. And popliteus inserts into the posterior surface of the tibia in a fan shape just above the soleal line. So this is a diagrammatic representation of the arrangement of the structures on the lateral aspect of the knee that are inserted into the fibula. The first is the lateral collateral ligament. Second is the popliteofibular ligament. Third is the popliteus muscle, and this is the biceps femoral insertion. So all these structures can be seen in the lateral compartment. The main arterial supply to the popliteus is from the inferior medial and lateral genicular branch of the popliteal artery, muscular branch of the posterior tibial artery, and a small nutrient artery of the tibia. The popliteus muscle is innervated by a branch of the tibial nerve. What are the main functions? That's the lateral rotation of the femur on the tibia, medial rotation of the tibia on the femur, to unlock the knee during knee flexion initiation, and protection of the lateral meniscus. And there are few variations of this popliteus. There can be an additional head from the sesamoid bone in the lateral head of the gastrocnemius. One is the peroneus minor. It is very rare. It runs from the posterior surface of the lateral tibial condyle, medial to the plantaris to the oblique popliteal ligament. And third one is the peronea tibialis. It runs deep to the popliteus from the medial side of the fibular head and inserts into the upper end of the soleal line. So coming to the stepwise approach for the evaluation, we have a lateral approach for the tendon and the myotendinous junction, coronal oblique approach for the muscle belly, and out of the interest, we can do the elastography for the tendon stiffness. So this is the basic patient position. The patient is in left lateral decubitus, knee is in flexion, supporting on the contralateral knee. This is the position which I have found very useful for seeing all the structures in the same position. And I prefer these two transducers. One is the 9L transducer, which gives a adequate penetration and resolution for the bursa and the muscle belly of the popliteus. And this 615 megahertz, the matrix probe for all the tendon and the ligaments. So coming to the evaluation of the popliteus in short axis, this is the position of the transducer. First, identify the bony landmarks. We can see the lateral femoral condyle, the popliteus fossa, and the lateral tibial condyle. We can see the lateral meniscus. We can see the oval hyperechoic structure in the popliteus fossa, that is the popliteus tendon. This heterogeneous hypoechogenicity is because of the anisotropy. Here, we can also see the iliotibial band and the superficial to the popliteus tendon, that is the lateral collateral ligament. For the long axis, we have to angulate the transducer with the proximal part of the transducer pointing towards the patella, so that we can beautifully see this parrot beak appearance of the popliteus tendon, where we are usually regularly seeing for the supraspinatus. Here we can see the bony margin and the entire tendon up to the myotendinous junction. So it's a small video. Here, after seeing in the short axis, we try to evaluate the entire tendon and the myotendinous junction in the long axis. We have to gradually rotate clockwise so that we can reduce the anisotropy and see the tendinous origin as well as the entire tendon. So coming to the muscle belly, evaluating, first I will do it in a long axis because that is easier. The transducer is in coronal oblique position. The patient is in same position. First, identify the bony landmark, that is the proximal end of upper third of the tibia. Here we can see a belly of the popliteus muscle with a linear striations within it. And in this, if we rotate the transducer slightly anti-clockwise, we can see this myotendinous junction and the tendon going towards the popliteus fossa. Here is the belly of the popliteus muscle. This is the tibia. And this is the myotendinous junction. So in this video, we can see the popliteus. This is a long axis view of the popliteus belly of the muscle. We can see the entire muscle. We can see the central aponeurosis within the muscle and the myotendinous junction. Coming to the short axis evaluation of the muscle belly of the popliteus, you have to just hold the transducer in short axis just inferior to the popliteal fossa. Here we can see this popliteus muscle belly just adjacent to the popliteal artery. So in this video, we can see the central aponeurosis of the popliteus belly and the popliteal artery as a soft tissue landmark for evaluating the popliteus belly. So another very important structure is the popliteofibular ligament. I think it is very under-evaluated in all ultrasound examination. This is a hyperechoic band extending from the popliteus tendon near the myotendinous junction to the posterior aspect of the fibular head. It is one of the strongest lateral stabilizer of the knee. I will explain the importance in next slides. So here we can see this hyperechoic band-like structure attached to the fibular head. This is the popliteofibular ligament, and few superficial fibers are getting mixed with the popliteus tendon, the fibers of the popliteus tendon. So this much is the popliteofibular ligament. So coming to the pathologies of the popliteus, I have divided into tendinous pathologies, pathologies involving the musculotendinous junction, muscular pathologies, and the pathologies of the popliteofibular ligament. So these pathologies can be acute or chronic. So this is a case of the popliteus tendinosis in short axis. It is commonly due to the repetitive stress and the microtrauma that can lead to popliteus tendinopathy. Patient presents with chronic, persistent, and chronic pain in the posterolateral region of the knee. So here we can see a diffusely swollen popliteus tendon with heterogeneous echo texture with no cortical erosion in the popliteal fossa. So in the long axis, we can see heterogeneous hypoechoic tendon, which is diffusely thickened, loss of fibrillar pattern. And in day-to-day practice, if we measure the thickness, most of the popliteus tendinosus cases, we have a diameter with a thickness more than 5 to 5.5. And usually it is between 3 to 5 mm popliteus tendon. So these are tears are the common thing involving the popliteus tendon. In this case, there was a history of trauma, and on evaluation, I couldn't see properly the cranial end of the origin of the popliteus tendon, and there was irregular hypoechoic areas and diffuse thickening of this tendon as well as the myotendinous junction. We do come across such intrasubstance tear, which we see in the supraspinatus or subscapularis. It's a linear cleft within the swollen popliteus tendon. This is a long axis view of the popliteus. So coming to the short axis, we can see a small thin cleft within the swollen popliteus tendon. So another case of the long intrasubstance tear, neither it was extending superficially or deep to the articular surface. So it was almost about a 10 millimeter of length and 1 mm in thickness. So in this case, we could see this oblique intrasubstance tear of the popliteus tendon. This was another interesting case. We could see an intrasubstance tear as well as a tear involving the cranial end of the popliteus tendon. Here it was a hyperechoic as well as a hypoechoic area within the diffusely thickened popliteus tendon and a collection of fluid in this area. So in this case, only a very few fibers on the articular surface of the popliteus tendon was intact. Entire tendon was torn up to the superficial surface. This is the same case in the short axis view. It was totally heterogeneous with small pockets of fluid within that. So another common presentation is the pain in the lateral knee. In this case, we could see two foci of calcifications. And after that, when we advised an uric acid level, he had a very high uric acid level of almost 10. So for such cases, we can attempt a barbotage. And in this case, we can see diffuse synovial thickening where the popliteus tendon was normal, but we may mistake it for any other pathology. But here the tendon was entirely normal, and the total synovial soft tissue thickening was seen superficial to the popliteus tendon. This was a case of rheumatoid arthritis. This was a very recent case. Yesterday I saw this case. The patient, it was a 28-year-old male. He came for a knee pain. And interestingly, when I evaluated this popliteus belly in long axis, I could see a large calcification, almost 10 by 5 mm, within the belly of the popliteus muscle. And in short axis, we could see such hyperechoic foci within the belly of the muscle. So another common clinical reference is for the post-TKR lateral knee pain. And nowadays, it has been very common for this post-TKR knee pain. So post-operative knee pain with or without mechanical symptoms should raise the suspicion for popliteus tendon impingement, fabular impingement, or periprosthetic fracture. Ultrasound provides visualization of the popliteus tendon origin and popliteal sulcus in the postoperative knee more effectively than MRI and radiography. Ultrasound allows dynamic assessment of the tendon with visualization of the tendon snapping over the osteophyte and correlation with the exact location of the pain. So these are the few cases, because I was trying to evaluate the pain generator for these cases. So when I saw this case, this was a case of post-operative post-TKR. Here the popliteal muscle was totally hyperechoic, uniformly hyperechoic, and a very thin tendon was seen. And in this case, I was not able to see the origin of the tendon. And in next case, there was a diffuse thickening of the popliteus muscle with no normal muscular picture in this particular case. And there was severe pain for this patient. And in this case, I could see the popliteus fossa with a short axis view of the popliteus tendon, but I was unable to see the popliteus tendon and the myotendinous junction beyond the prosthesis in this lateral femoral condyle. So this I have taken from the AOM journal. Osteophyte at the inferior aspect of the popliteus sulcus that can also impinge on the popliteus tendon in the short axis view. I have not seen it such case, but this is a possibility for the lateral knee pain in post-TKR status. So this is also very under-evaluated, that is the popliteal bursa. It may receive extruded flaps of the posterior horn of the lateral meniscus or extruded lateral, the loose bodies. This bursal fluid can rupture and give rise to severe lateral calf pain, mimicking a calf muscle strain, or which is the another common presentation is popliteal cyst rupture extending the fluid superficial or between the gastrocnemius muscles. But this has to be evaluated. So this is the position for the evaluation of the popliteal bursa, just adjacent to the belly of this popliteus muscle. So in this case, we can see a longitudinal collection of the hypoechoic area with soft tissue in it. Here, the synovial tissue was thickened, and it was superficial to the myotendinous junction and extending superficial to the belly of the popliteal muscle. This is the popliteal artery, this is the bursa, distended bursa, and the belly of the popliteus. And in this case, just bursa was distended at the level of the myotendinous junction, whereas the popliteus belly was normal, and we can see this normal popliteal artery. So coming to the popliteofibular ligament, this is in this case, we can see both the torn ends and with a small gap here, and this bright hyperechoic structures at the fibular head. And in this case, the popliteofibular ligament, there we can see a oblique tear just superficial to the popliteus tendon. It was involving the cranial two-thirds of the popliteofibular ligament. And in this case, I was unable to see the popliteofibular ligament beyond this area from the fibular attachment. So reviewing the literature, I just got these three important things. During TKR, if the lateral side is tight in extension, iliotibial band is released. And if the lateral side is tight in flexion, popliteus tendon is released. And if the lateral side is tight in flexion and extension, LCL is released. So we should be aware of these things while evaluating a post-operative post-TKR knee, because all the pictures which I showed previously, because I was not aware of these things, only after reviewing the literature, I got these answers. Why we are seeing different pictures in different patients of the TKR involving the popliteus tendon and the myotendinous junction. So I just tried an elastography, the 2D shear wave elastography of a normal tendon. Here I got a values of 35 to 45 kPa kilopascals in this normal tendinous area. And this is the propagation wave where we can correctly put the measurement box to get the correct values. So in this case of popliteus tendinosis, I got a value with a reduced value that was 17 to 18 kPa. Coming to the conclusion, the high resolution ultrasound is an excellent, easy available modality to assess knee joint, especially the popliteus. Thank you very much for kind listening. And I also thank my better half Kirti, who is a pain consultant and who daily refers all these knee cases. And so I could dive deep into the knee after the evaluation of the ACL, which I could present in the previous AIOM. So thank you all for kind listening, and thank you, Ankit.
All right. So I think this was, I have to really thank Dr. Satish for presenting a completely different perspective to the popliteus tendon. I mean, I I don't evaluate the popliteus tendon ever in the day-to-day protocol, of course, but popliteus tendon is an important site for crystal deposition disease. In fact, if you look at hematology literature, they have a lot of these grading systems as well. So yes, that's where popliteus tendon is important, even in the post-arthroplasty knee. Yes, it is. So I think, thank you so much, Dr. Satish.
Yeah, thank you very much. Because
I have no.
nowadays, every alternate case of TKR, I think we can easily evaluate, at least for this lateral posterolateral knee pain, and it is very easy. I think it should help all of you. At least we can see the popliteus in a better way.
Yes, superb, superb. Sir.
Thank you.
Yes. So,
have I stopped the screen sharing?
Yeah, it stopped.
Yes, sir.
Yeah.
Yes,
thank
it
you.
stopped. So, if anybody has any questions, feel free to ask. Because this is a completely new topic. Okay, so, sir, Dr. Karthikeya wants to want you to show the slide of the popliteus tendon checklist. What all things do we need to check?
Okay.
We'll just have to share it. So one more question while you do that. These popliteus tendon tears, are they seen in isolation, or of course you said that it
Because all the
coexists with
cases
other.
which I have seen, that was in isolation. All these
Okay.
intersubstance, not associated with the other ligamentous injuries.
Mhm.
They had some sort of trauma, and they came. It was a long-standing history, and they came for evaluation of the knee pain.
Ankit,
Yes. Yes, sir.
I have seen few crystal depositions in the popliteus tendon. But as Satish has shown very beautifully, I haven't come across isolated tear as such. It is usually the tendinosis of the popliteus tendon with lateral meniscus injuries, what we come across. But I haven't seen a isolated full thickness or intrasubstance tear so far. But it was a very nice presentation by Satish, and we'll keep on looking into popliteus more in detail. Thanks, Satish, very much.
Thank you, sir.
Okay. So I think, sir, you want to show that slide, or if it's difficult, then we can show it. Yes.
But means I have to show him the checklist.
Yeah, if you could just show the checklist.
Yeah, 1 second.
If you could just show the checklist. Yeah.
No, the one previous one, Satish, where you can see all three structures.
Or this one?
No. Yes, this one.
So in this section means basically we first see the iliotibial band, lateral collateral ligament, then popliteofibular ligament, because entire all these structures we can evaluate in one go. So that becomes very easy rather than doing just individual popliteus tendon analysis. Anyway, we have to see all these structures for evaluating.
Satish, I have one.
Yeah. Tell me.
Satish, I have one small question. When you look at the lateral collateral ligament in a long axis, can we very definitely separate popliteus tendon from the lateral collateral ligament, or there is merger of fibers between two?
Then in the cranial third, we can see the merging of the lateral collateral ligament just here, because here the lateral collateral and the superficial fibers of the popliteus tendon get merged, so we can see that. Yeah, and just near the fibula we can see the oblique popliteal ligament.
Thank you so much, Dr. Satish. I think this is something which I will have to work on from tomorrow onwards. And if you all have any questions, you guys know whom to contact. Whenever you feel that there's a popliteus tendon pathology.
Yeah.
So
anything to improve?
So
pardon?
No, anything to improve in these cases? Any suggestions?
There is a lot of scope for us to improve.
Yeah, it's a fantastic collection of cases. All superb. Just superb.
Sir, I wanted to ask you, sir, you said that you have done barbotage. Have you?
No, I have not done
the popliteus
I have not done the barbotage
injection
for that particular case.
Okay.
I think in the future we can, means as if we do.
Neither I have injected or done any barbotage in popliteus.
Yeah. Right. True. So I think if you see, you don't need to inject the popliteus tendon sheath separately. Even if you do an intra-articular injection, that steroid will flow in the tendon sheath, because technically the popliteus recess or the tendon sheath
that takes care of that popliteus belly also.
Okay. Right.
So that's why we usually don't do any injections for that popliteus tendon.
So if there are no other questions, I think we can go ahead with the next session by Dr. Raleigh.
Can I share this? Hi.
Yes,
can I share the screen?
Yes, please. Share it?
Yeah, just share.
Awesome. So good. I think Dr. Raleigh, please introduce yourself, and the stage is all yours.
Yeah. Hi. Just a second. Yeah. So good evening, everyone. I'm Dr. Raleigh Chaudhary, consultant in Kokilaben Hospital, Ambani, Mumbai. After a comprehensive evaluation of popliteus tendon, Dr. Satish, it was wow. I've never seen such good images. You explained it beautifully. So now we are looking at some common cases. It's a mixed bag of cases which we have done. We have evaluated it, and post-operative follow-up is also there. So my first case is a aged man who was also diabetic and came with significant pain, tenderness on the volar aspect of the elbow and forearm. So if we see here on clinical examination, there was subtle soft tissue swelling, erythema on the volar aspect of the forearm, and there was a lot of tenderness, which made me suspect that something is really going wrong. So so we did an ultrasound for this patient. Just a second. So on high resolution ultrasound, I just saw the joint and I could see there was some joint effusion in the radiocapitular and the trochlear joint recess. So when I scanned the site of the swelling, there was a lot of edema and there was thickening and distortion of the facial planes. So as we can see, this is subcutaneous fat, this is fascia, this is muscular compartment. So there was a lot of thickening of this plane and there was some fluid collection which was quite turbid. When I saw it on panoramic imaging, this was a huge collection, turbid fluid collection in the between the subcutaneous tissue and the muscular compartment. And this collection extend from the forearm to the volar aspect. So we can see that there is a lot of echogenic foci with dirty shadowing, which was showing a twinkling artifact, which made me think it is air. So there was, if you can see in this video, these were all mobile internal echo and debris. The beauty of ultrasound is if you are suspecting a collection, if you do compression, then you can see the movement of these echo and debris. So because it was, I was suspecting a case of necrotizing fasciitis. This was a surgical emergency. The patient was immediately taken for a CT, and we can see that there was a lot of air in the fluid collection here and facial thickening and stranding. So as you can see, there was a lot of air in the fascia. And then the patient was immediately taken for surgery. There was debridement which was done at the site of the swelling. So as we can see, there was a lot of distortion of the fascia, thickening, and this was the collection. And this is the post-debridement case. So basically necrotizing fasciitis, it's a rare entity, and it is a fulminant necrotizing infection of the soft tissue. So ultrasound helps us in clinching the diagnosis with thickening of the fascia. And as soon as I saw the guess, this was really worrisome. So the patient could be treated. My second case was a case of AV graft surgery. And this patient presented with a soft tissue swelling. He was very anxious. And since 1 month, he was moving here and there and couldn't get an answer. There was discharge. And as I started, there was again a subcutaneous edema. As you all can see, there is the graft vessel and with a lot of turbulent flow here. And as there was an outpouching, which is coming from this at the level of this palpable swelling, which was showing a very classical to and fro flow pattern and yin-yang pattern, and very classical of a pseudoaneurysm, which was formed from this graft vessel. Another thing, I saw the neck of the pseudoaneurysm, which was communicating with the graft. So when I saw there was a well-marginated collection or heterogeneous collection which is surrounding the graft in the perigraft region and the pseudoaneurysm. On putting color, there was significantly increased peripheral vascularity or hyperemia. So the final diagnosis made was pseudoaneurysm from the graft due to the graft injury due to repeated punctures, and there was a collection and there was a possibility of infected hematoma. So our vascular surgeon in our hospital did the exploration and sent me this intraoperative pictures where there was graft was torn due to repeated punctures, there was pseudoaneurysm formation, and there was an infected hematoma. So false aneurysms, also known as pseudoaneurysms, they, as we know, they are outpouchings which are only bounded by tunica adventitia. And ultrasound is very classical. We don't need any further imaging modalities. You see a typical yin-yang sign and a two-flow pattern on ultrasound. So my next case is a 46-year-old female. She was the mother of a dermat who came to me that since few months, 5 years, they are not able to clinch the diagnosis. This was a painless soft tissue swelling, and they were thinking it in terms of sebaceous cyst, and they were planning for a surgery, but they came for a second opinion here. So when I saw this patient, I could see that there was a well-marginated lesion in the subcutaneous tissue of the scalp. But as soon as I put color, what I saw, that there was multiple tubular serpingeous channel, which was showing low resistance arterial and venous flow. So as we can see here. So in this patient, I used, because it was a very superficial, the lesson that you should put very less pressure on the probe, lot of gel. And what I could see that there was a feeding artery which was leading to this lesion. And this was coming from the superficial temporal artery in the preauricular region. So I compared both the sides. So this side, the symptomatic side was dilated and tortuous superficial temporal artery. As you can see, this was coming till the lesion, this feeding artery. So my diagnosis was a extracranial arteriovenous malformation of the scalp, which is again a rare entity. And ultrasound helped us in reaching the diagnosis. And doctor was strongly suspecting a sebaceous cyst. By ultrasound, it completely changed their decision and treatment making. So AV malformations, they are basically tangle or leash of vessels, and patient present with palpable mass. You can also hear a thrill, but not always. So it is seen as multiple tangle of vessels and with mixed arterial and venous flow. It is very helpful if we see a feeding artery which is reaching the lesion. So a similar case was another patient who presented with a painless swelling in the temporal region for 3 years. So when I saw there was a bilobed, well-marginated lesion at the site, and there was no probe tenderness. But as soon as, again, they were suspecting a dermoid cyst, but what I could see that there was echogenic intraluminal material and there was some flow inside, which was showing both arterial and venous spectrum. So when I put the color, it is like this. So again, with lot of gel and very less pressure, when I saw, I could see a small feeding artery, very thin feeding artery, which is again coming from the superficial temporal artery and was reaching this lesion. As you all can see, this is the artery which is reaching the lesion. So this is here. So my final diagnosis was a partially thrombosed arteriovenous vascular malformation. The surgeon was convinced and patient was taken for surgery. Post-surgery, the diagnosis was correct. So here I felt that ultrasound really scored our other modalities in terms of high spatial resolution, patient convenience, and less cost. So thrombosed AVM can present as a long-standing swelling and can transform into a painful lump. Important is it is vascular and there can be a filling defect or a thrombus. This is a very nice, interesting case of a 45-year-old man. He said that since 5 years, he is having these bulges or lumps in his leg, which becomes very prominent on activity like squatting when he's running. And recently, he's started developing a lot of pain in these bulges. So when I did a dynamic scan at rest, there was no visible swelling. But when we did the stressful dynamic activity, we could see that there was a bulge, there was a defect in this fascia, and there was a bulge of the muscle which was herniating through the defect. What we could see that there was a perforating artery which was present at the level of the facial defect. So if you compare at the rest, there was the defect in this fascia is this, and this is the muscle bulge. And during stress on dynamic maneuver, this bulge was very much prominent. So what we could see a mushroom-shaped bulge in the muscle which is herniating through this defect in the deep fascia and was becoming on rest and on stress was becoming very prominent. On panoramic images, we could see a lot of in continuation defect in the muscle, and this was tibialis anterior, which was herniating in the muscle. But because the patient was very apprehensive and he wanted a treatment, a surgical repair, so our orthopedic just sent him for MRI. But to my surprise, MRI was not very helpful. I got a call from MRI that where are the defects? Then they placed a marker. They could see very small thinning or defect in the fascia, deep fascia of tibialis muscle with fat herniation. So this patient was taken for surgical repair. But the commonest muscle to herniate is tibialis anterior. And the history which patient gives us is that he see bulge which becomes very prominent on the anterolateral aspect of the leg on any activity, and this can cause pain. And so the modality of choice after seeing these images is ultrasound because of its dynamic character. So what we do here is known as dynamic muscle ultrasonography at rest and at stress. Very light pressure is preferable. Hernia is often hypoechoic. You can see the bulge on dynamic evaluation through the facial defect. So treatment is management conservatively, but if it is causing a lot of pain, then surgical repair, but you have to take in care that there can be a risk of compartment syndrome. Differential diagnosis is vascular malformation, benign soft tissue tumors, but on dynamic evaluation during stress, you can see very well the muscle herniation. So ultrasound is the gold standard for this. The next case is a 39-year-old man who, while playing cricket, felt a snap-like sound. So on high resolution ultrasound, there was a large hematoma which was well marginated, basically in the myoaponeurosis of the medial head of the gastrocnemius, and this was extending between the gastrocnemius and the soleus muscle. You can see that there is distortion of the myoaponeurosis. This is classically known as tennis leg deformity. Because it was common in tennis players, but it is, I see it it's a very common entity while playing cricket. In the classical history, after running, patient gives a sudden sharp pain with sensation of something snapping within the calf. This can present with huge swelling, but on ultrasound, you can see that there is a fluid collection, and in the myoaponeurosis, there is a tear in the medial head of the gastrocnemius. Normally, in our institute, we don't need an MRI for this. Ultrasound is enough and is the modality of choice. Treatment is mainly conservative, and it's a self-limiting condition. What is important here is its differential diagnosis. Deep venous thrombosis also comes with pain in the calf. So you have to exclude that out, or a ruptured Baker's cyst. So next case is a patient who came with a history of road traffic accident few months ago and soft tissue swelling. So as you can see, there was a long, on panoramic imaging, you can see a ovoid fusiform collection with few septa in the deep subcutaneous plane, and it was closely abutting the muscular fascia. As you can see it here. Again, it is in the, it's in the facial plane and it's abutting the fascia of the muscles. So this is a very classical entity which is known as Morale-Lavali lesion. It is a close deglobing injury which is associated with severe trauma, and there is hemolymphatic collection, and common site is thigh. So normally there is a collection which resolves on its own, but sometimes it becomes encapsulated, and in such cases it can have debris, septa, and ultrasound nearly suffix, and we don't need any further modality. So if this lesion becomes encapsulated and established and it's not getting treated, then surgical drainage can be done, and we have to, capsule needs to be resected. What is differential? If it's in the classical location and has a characteristic appearance, there is less differentials which exist. But if there can be fat necrosis, subcutaneous hematoma, hemangioma as the differential diagnosis. Now, this is again a common case. A young male came with a painless soft tissue lump in the. So this, as we see, it is a well-marginated lesion with posterior acoustic enhancement, lateral shadowing, and there was multiple punctate calcific foci, this linear anechoic filiform pattern, and a classical appearance of what is known as pseudo-testis appearance. No internal vascularity. This entity is known as epidermoid inclusion cyst. These are very common soft tissue lumps which we see, and they are slow growing masses. You can see a punctum which is coming with that. Again, you have to see with very less pressure and a lot of gel application. So ultrasound is sufficient. It is a spotter in many cases, well circumscribed avascular mass in the subcutaneous tissue plane, and linear filiform pattern, this onion-like appearance, pseudotestis appearance, a punctum draining it. So we don't need any further modality, and ultrasound is sufficient. This was a case which I did today, why I placed in the presentation, because this is the commonest soft tissue mass. This was a lady who came with a painless soft tissue swelling and was worried from cosmetic point of view. And when I did it, it was a well-marginated focal hyperechoic lesion with a very classical appearance of these linear striations, which was parallel to the skin surface. And this is again a spotter, only one diagnosis, very classical subcutaneous lipoma. The surgeon who sent me was thinking in terms of epidermoid cyst also, but on ultrasound, there was no internal vascularity. It was very classical of lipoma, subcutaneous lipoma. These are the most common soft tissue tumors. Why I place this case? In many cases, ultrasound help us in triaging the lumps. If they are completely benign, you are sure you don't need any further modalities. So in such case, these are lipomas. They can be encapsulated. They are typically hyperechoic. They don't need any further modality. But if they are heterogeneous, they are huge, they have internal flow, they are deep, then you need to rule out suspicion of liposarcoma. In that case, we need to go for MRI. This is my last case of the day. This is a 52-year-old female. She came to me with a history of carcinoma of the right breast, for which chemo and radiotherapy was done. And recently she saw this swelling on the posterior medial aspect of the thigh. And there was no pain. She was worried. They did an MRI outside where they give the diagnosis as AV malformation. But our oncologists were not happy and he sent me for the further evaluation. So what I saw here, that there was a lobulated, multilobulated, heterogeneous, complex lesion in the subcutaneous tissue compartment, and was not looking good to me at all. So when I switched on color, there was increased internal vascularity with arterial and venous spectrum. Was looking very suspicious, and when I can always compare with the sites. So here you see that in this case, because there was a history of primary breast carcinoma, so I laid the possibility of metastatic etiology first and primary soft tissue sarcoma. Then the MRI, which was done outside, was sent for a review to our consultants, and they saw it. So it was a heterogeneously enhancing lesion in the subcutaneous compartment, which was significantly enhancing. And here MRI was a must because it was suspicious and we could see these findings. So they also gave it as a primary soft tissue sarcoma oblique metastatic etiology. So these were then a PET CT was also done, and we can see this FDG avid nodule in the subcutaneous plane. So it was strong suspicion of a malignancy. So the patient was operated, and we can see that this was a specimen, this was the malignancy, and this is a surgical bed. So discussion is soft tissue sarcomas. There are heterogeneous group of rare malignancies. Commonest site is extremity on trunk. They present as a painless soft tissue lump. Basically, if we are suspecting it, we have to go for histopathological correlation. What is the role of ultrasound here? First is the primary modality. When a patient comes with a palpable soft tissue lump, the first investigation of choice we do is ultrasound. Why? Because, as I said, I showed you a few benign cases of lipoma, epidermoid cyst. So it can help us in triaging the lumps, whether they are looking benign or they are looking aggressive. If they are looking benign, then we don't need any further investigations. But if they are not looking good, they are looking aggressive, then we have to go for cross-sectional modalities. And ultrasound, in case of sarcomas, are heterogeneous complex mass lesion with significant internal vascularity. It will help us in locate the depth location, whether it's superficial, deep to the fascia, intramuscular, and the depth of the lesion. It will help us in characterizing whether the lesion is cystic or solid. And it's very helpful in our institute. I'm sent the patients with follow-up for post-operative status to look for any local recurrence and also for guiding biopsies. It's also helpful in cases of orthopedic hardware. Doppler can help us in this case, in distinguishing a recurrent tumor from avascular fibrotic tissue of the resection bed. So treatment is surgical resection, and radiotherapy can be used as an adjuvant. So these are ultrasound characteristics of benign and aggressive. Benign is well marginated, is avascular, is usually smaller in diameter, and has a well-defined margins, while aggressive is hypervascular lesions. Then heterogeneous solid lesions with ill-defined margins. They're commonly deeply located. And as we saw, synovial ganglion cysts. Very important, ultrasound can help in suspecting a recurrent soft tissue sarcoma, and further imaging can be done for the same. So in this case, the patient was saved on ultrasound. I raised a suspicion. Then further modality was done and patient was surgically treated. So thank you. These are the cases for the day. I'm done, Ankit.
Yeah. So thank you so much for presenting this such a fantastic variety of these cases. So if anybody has any questions, feel free to ask. So I want to ask regarding a couple of cases. So the first one, wherein you saw a gas gangrene.
Yeah.
Could you tell the surgeon, yes, that this is gas that you're looking at, and why was CT done? I mean, there are two things. And what was the final?
Sorry,
why was the CT done?
So
What extra did they want to know?
So what happened? See, Ankit, what happened when the patient came to me? They were not suspecting it to be necrotizing fasciitis. So when I saw these when I saw these echogenic foci with dirty shadowing, so I could see that moving with twinkling artifact. So I raised a strong suspicion that this is air. And air means we are looking at a gram-negative infection. And in a case of diabetic patient, then suddenly I thought, if I'm looking at necrotizing fasciitis, I called my surgeon. And they were like, if I'm taking it for the surgery, let me first do one CT also. But I gave them the diagnosis that this is this. And they just did it for pre-surgical thing.
All right. Yeah. Okay, that's great. I understand. Okay, so then what was the final organism that they grew? The bacterium? Any idea? What
Staph
was?
aureus and Clostridium difficile.
Okay.
Clostridium.
Okay, great. The other question I had is, regarding the tennis leg which you showed. I think that was a fantastic panoramic image. Do you give any classification system? Do you use any classification system while doing the reporting, or it's not?
See, if it is just as I measure the size of the hematoma in grade 1 injury, it's mostly just you see some thickening and distortion of the myopeneurosis of the medial head of gastrocnemius. Then if there is a small hematoma, I quantify it and I inform my doctor that there is a small hematoma, and if there is huge, then it's grade 3. But anyways, they are treating it conservatively. They are not doing any surgery for it. I have seen huge hematomas, which has resolved spontaneously over time. They came for follow-up to me also. Slowly and slowly, they resolve on their own. So they never treated surgically, but I always mention the size of the hematoma and the collection in the tennis leg deformity. Yeah.
I don't think, Rolly, that Ankit is asking. I think what he's asking is that when you classify, do you classify how close to is the FGR involved, not involved? Because size of the hematoma and volume of the hematoma really doesn't have much reference to the grading.
Okay.
The grading is whether the aponeurosis is involved, how much of the aponeurosis, what is the
ma'am. So
FGR. So that part, I think that's what Ankit is asking. Am I correct, Ankit?
Yes. Yeah. So what I want to ask is, yes. So what are the parameters that you use to describe? For instance, when you use a British athletics system, you measure the craniocaudal distance, the amount of retraction, the cross-sectional area of the muscle. Do you try and report that way, or you use a simplified system, which is grade 1, grade 2, grade 3, which is by Petrons, which is much more easier?
I don't report it that way. Yeah. I just say it's initial stages. Yeah. I say thickening, distortion of the myopeneurosis, loss of the pattern there. And if there is I don't report it by grading by that system. Yeah.
Okay.
But
That's fine.
Ankit,
Yeah.
yeah, because most of the orthopedic surgeons, what we find in Delhi are not very familiar with the
Yes.
grading that is reported in
Mhm.
our ultrasound practice. Most of
Yes.
them are happy knowing what Rolly is saying, that
Yes.
kitna bada epineuritis kahan tak ja raha hai, and
Yes. Avulsion
plantaris hai
injury.
ki nahi. Yeah, avulsion hai nahi hai. They are not even very particularly informed about what is the importance of involvement of FGR or not. It's a very strange thing
Yes. Yeah.
because 91.9% don't want to do anything.
In fact, Dr. Nidhi, recently one of my
Conservative.
orthopedic asked me, so what should I do about it?
Yeah, exactly. Exactly. हम तो कहते हैं छोड़ दो. Yeah, exactly.
Yes.
Because tennis leg, 99.9% they say, छोड़ दो, it'll heal on its own. Unless, of course, the patient is an athlete and return to field is important.
Yes. I agree, ma'am.
Yeah.
Even if the
No.
patient is an athlete,
So
they won't go.
yeah.
Yes. Go ahead.
So most important is in the elite athlete, because return to sporting activities, they have to tell them when they will be able to return to the activity. And if there is a injury to the aponeurosis, the time to return is longer compared to the just a muscle injury. That's a very important factor according to me.
I agree, sir. Absolutely.
And that
But still, I'll tell you something. Sir,
hello.
koi nahi kuch kar. Yeah. They don't do anything. They just say 6 weeks बाद
Hello.
देखेंगे, bandage बांधो, and be happy with that.
Yeah.
Yeah.
Yes. So I agree. Even with these large hamstring injuries, wherein you see the entire biceps, semitendinosus, semimembranosus is torn from the ischial tuberosity. If the patient is not an athlete, they will still manage it. The patient conservatively, they won't do anything. Yeah. So true.
Can I ask Dr. Satish a few questions?
Yes. Please.
Hi,
Yeah,
Satish.
welcome, ma'am.
क्या तुमने कीर्ति को लगाया है कि सबकी टांगे तोड़ दो? इतने
Absolutely
सारे
not.
cases. I mean, I have seen just one Popliteus tear, and as Dr. Ketkar said, I agree with him that isolated Popliteus complete tear is a very rare thing to happen.
नहीं, उसको जोर से लग गया था. Means he had a severe.
हाँ, अरे मुझे मालूम है कीर्ति बहुत जोर से मार सकती है. So, but jokes
But
apart,
I felt very interesting to dive deep into
uh-huh.
after ACL. I was just searching because I was not getting the answer why the patient is getting pain. So I started evaluating all these small things.
No, that's absolutely right. But I also agree with Dr. Ketkar on a very important aspect that every time you come across popliteus injury, it's just mandatory that we should look at the lateral meniscus and also the capsule, because the capsular tear and the tear of the lateral meniscus, the posterolateral component, they go hand in glove.
Yeah.
Isolated popliteus not involving the capsule, when we are talking of complete tears, जो आपने 2-3 cases दिखाए हैं, if we don't address the capsule and we don't address the lateral meniscus, then we are leaving.
We try a lot
in
for the lateral meniscus, ma'am, but we cannot go beyond we cannot evaluate properly the lateral meniscus on ultrasound. That is my experience.
Posterolateral is one of the easiest. Anterior and mid body, very difficult. But posterior components
posterolateral
of
we can
both
see
medial,
posterior. Yeah.
lateral meniscus, I mean, we can see them very nicely because there are no overlap of the bones. So we can see them. But I do believe that posterolateral corner injuries, because if popliteus is gone, the posterolateral complex of the knee joint हिल चुका है. We need to be very careful in young people, and we should actually make one step ahead. So just leaving it at, I mean, there are a lot of cases. I loved the way Ankit asked, Rolly, OCT क्यों करवाया? I loved that question because most of the cases,
I was so confident.
Rolly, I
Sorry.
agree. But Rolly, that is a fantastic question Ankit asked because आपके most of the cases के अंदर, it was like you said, ultrasound clinched the diagnosis. So क्यों करवाया? But when it comes to Dr. Satish cases, I would definitely want an MRI to rule out posterolateral coronary injury of the knee joint. Definitely.
Yeah.
I would not believe with that major an injury of the popliteus tendon. I wouldn't want to leave that knee joint just saying, don't get an ultrasound, MRI. I would. Anybody on that, sir? Ankit, Rajesh?
Another reason why this posterolateral corner injury is whereas you will often find, or rather not often find, it's often associated with a tibial plateau fracture, posterolateral rib. So
Absolutely.
those chondral injuries and the fracture is, ultrasound is not a great modality for that. So
Yeah,
and these fractures are not that well seen on MR as well. So that's why I think MR is absolutely essential in these kind of cases, where you suspect a popliteus tendon injury.
Yeah, see, because the popliteus actually prevents the external rotation, ना?
Yeah.
तो आपका externally जब rotate हुआ है, so it takes away a lot of, I mean, for a popliteus injury, if I can see, I would definitely ask for an MRI. I will not leave that. Because the first thing that they ask you is, at least ये वाला जो एक था, the first thing he asked was capsule intact है कि नहीं है? ऐसे कितना funny question है बाबा. I mean, we can't see capsule on an ultrasound. We can see lateral meniscus, but we can't see the capsular tear on an ultrasound. So they went for an MRI. Of course, there was a tear. But then again, I don't know whether they would want to do something about it or not. And this is just a little small comment that I'm making, that popliteus tendon does not have an origin. It just has an insertion because the popliteus muscle starts from the tibia and it goes supralateral, and the tendon takes its insertion in the popliteus groove. So effectively, there is no origin of the tendon. It's just the insertion.
Grace, it is mentioned as you mentioned rightly, and in other textbook they have done it in the other way. Grace anatomy, it's the same description which you have.
I am also confused with the origin and insertion. Somebody says it's originating from the popliteus.
It's insertion. It's insertion everywhere. I mean, there is a fantastic, absolutely a fantastic, written in 2009 by Robert Cook about the ultrasound of posterolateral coordinated knee. I think it's the probably the Bible. It's just one article, very short article, but it is absolutely a Bible of ultrasound of knee joint. And the descriptors are very, very solid descriptors there. So anyhow, everybody, Rolly, well done. Very interesting cases. And Dr. Satish, thank you for coming up with a brilliant topic again.
Any other muscle in the body which have a muscle origin caudally and tendon distal cranially?
एक मिनट.
Subscapularis, I think.
Correct.
Subscapularis one, where cranially they have a tendinous origin, and that is lower 2/3 is a muscle. Same way, I think even if you look at the gluteus medius, it has got two origin. The posterior is a muscle, it is a directly muscle attachment, and so that's I think those are the two things I can remember often.
Subscap, yes, subscap.
I think this
Even short head of biceps femoris, it has a direct muscle origin, and it is tendon.
And in popliteus, it is the other way around. The muscle belly, entire muscle belly is inferiorly, and the tendon is totally cranially.
Yeah.
In subscap, it is at least horizontal or oblique.
Okay. Yes, Upasana was saying something.
I just said I have seen a few cases of popliteal tendon injury, usually associated with osteoarthritic changes.
Correct. Yeah.
Yes, ma'am.
Totally.
No history of injury, but there is osteoarthritis severe.
Right.
But to my experience, these post-TKR cases are very, very nice to evaluate on ultrasound because we can give many answers
Right.
right at the doorstep.
And Dr. Satish, that
Yeah.
vascular color signal that you showed, you said popliteal artery. Could
That
that
is the
be the
popliteal artery.
lateral genicular artery?
No. That is a big, because I have taken a coronal oblique view, ma'am. And in that view, it's not a circular one, it's an oblique view of that particular popliteal artery, just before the trifurcation.
That would be on the muscle, right?
Adjacent to the muscle, just adjacent to the muscle.
Because popliteal muscle will form the base of the ear.
Correct.
Yeah.
Correct. No, because
Just
one
the
of
oblique section.
the ways of diagnosing, you said the popliteofibular. I'm having a little doubt about what you showed, that popliteofibular ligament also, because popliteofibular ligament is a very short ligament. You've
Yeah,
shown.
but we can see that, ma'am.
Oh, we can.
थोड़ा doubtful था, longer one.
Short है. Long axis में आपने वो arcuate या fibular ligament.
Fibular.
Yeah, because the longer ones are just arcuate and
But I was also not so sure for that.
Yeah, because popliteofibular is very short.
Very short, around 20 mm.
Exactly.
Maximum 20 to
आपने
25.
बहुत लंबा सा उसको दिखाया, so I was having a little bit of a doubt there that and you would have been able to diagnose it so much better if you would put your color map and popliteofibular ligament के ऊपर 1 मिनट में lateral genicular
inferior lateral genicular आता है.
Exactly. उसका और कोई purpose नहीं है, वो शायद ultrasound वालों के लिए ही बनाई गई. So I keep saying thank you for it. But
Yeah.
I mean, that would have given us a clue whether you were in the fibula or popliteal, because they are very close by.
Fibular is posterior to the genicular vessels.
Correct.
Genicular vessels.
Yeah, absolutely. Yeah. But it's I think it's a great modality. Absolutely fantastic. You get totally rejuvenated by everything that you see.
Yeah.
Fantastic. Yeah. Thanks.
Thank you, ma'am.
Okay. So I think if there are no more questions, then we can conclude the session.
Yeah.
Great.
Nice cases, Rolly.
Yes,
Thank
so
you.
I think this was a superb session. I mean, thank you, Dr. Satish and
Yeah.
Dr. Rolly, for the same. And those who have missed the previous webinars, you can see it. They're available on YouTube. See it. They're available for free. So in case you want to catch up, and please do join in next week. Next week we have Dr. Subinay, as well as I think Dr. Rajas has also agreed to join in next week. So we'll be having some great topics as well. So thank you so much, everyone.